Good afternoon, everyone. I'm Mark McClellan. I'm the director of the Duke Margolis Center for Health Policy. I'm very pleased to welcome you all today, both in person and online, to today's event with our scholar in residence, Frederick Assassi, on the evolution of the healthcare movement, the value imperative. Health Policy Talk, this series, is a speaker series intended to highlight innovative and evidence-based ideas to help us move forward on important challenges in healthcare and health reform across a range of health policy topics. So what we try to do is bring together some of the nation's thought leaders with a set of activities here. You're joining us for the main event lecture, but we also have time with our visiting scholar, with our students, with our faculty, on how we can improve the connections between what goes on in the world of research and policy analysis and what goes on in actual policy making and implementation, something that's of core importance to the Duke Margolis Center for Health Policy. This series brings speakers in on a regular basis throughout the year, so if you're not already on our mailing list and Frederick got you to join us, please do stay tuned and get on our mailing list. We can tell you about future events related to key issues in health reform, the value of healthcare transformation, improving public health, and other issues that are at the center of the Duke Margolis activities. But right now, I'm very pleased to welcome longtime colleague Frederick Assassi. Frederick is currently the executive director of Families USA, which is one of the nation's leading nonprofit, nonpartisan health advocacy organizations. I think health advocacy doesn't do it justice. You do a lot of advocacy, but you do a lot of analysis and a lot of, and we're going to talk about it, community engagement and building engagement around some of the most challenging issues facing our nation. The goal of Families USA is to ensure that the best health and healthcare are equally accessible and affordable to all. This is not a new mission at Families USA. It's been part of Families USA for decades. I think Frederick's brought it to a new level with his leadership there. Frederick comes to this job from really working in all aspects of healthcare and health reform. He was at the advisory board to begin with, or earlier in his career, maybe not to begin with, also had a chance to work on Capitol Hill with then Senator Jeff Bingaman from New Mexico, Senator who I remember back then trying to make bipartisan progress on important health reform issues. Since his time there and at the advisory board company, Frederick went on to lead the National Governors Association. So in terms of its health policy work as vice president and founder, as division director at the Bipartisan National Governors Association, and went on from there to work at Families USA. But before all of that, he spent some time here at Duke University, at the Duke University School of Law, and also down the road at the University of North Carolina, where he got his master's in public health. And he's put all that together in his career. So Frederick, we are really glad to have you with us today, and we really appreciate your support for the center and your support for really driving effective healthcare reform in the United States. Thanks so much for joining us.
Absolutely, Mark. Thank you so much. Can you guys hear me? Should I bring it up a little bit more? I'm good? Okay. So just want to say, just start with a big thing. It's great to see everyone. Thank you for coming out to hear this. I hope it's really engaging and we can have time for questions. And, my favorite questions are the tough ones. So guys, really come at me with your hardest questions. I did want to say a very big thank you to Mark and to the center. It's hard to explain the imprint that the center is making on national health policy already after just about 5 or 6 years of really hard work. And it is a joy to be here. It's a joy to be a partner with the center and with Mark, with the ultimate goal of the idea that in this country, we should be able to have access to our best health, right? We spend more than any other nation on healthcare, sometimes 2 or 3 times more. We have some of the worst outcomes. We'll get into that in a second. And we rise or fall in the ways in which we can access our health. It allows us to self-actualize. It's at the foundation of who we can be in our society. It's very, very important. So let me go through this. I know we're going to do about 25 minutes or so of this, and then we're going to have questions and all kinds of interesting things. So, and if you have a burning question while I'm going through this, please just raise your hand. And I also wanted to acknowledge Deborah Ness, who has been working on this issue for so long and has been working on behalf of consumers for so long. And it is a joy to have her here. So you better believe it. Okay. All right. So let's see if this works. I'm going to try that. Here we go. Okay. So let's see. Maybe I should just call out advance. Okay, here we go. So just really fast, Families USA. We are, we've been around for 40 years plus. We are a leading national nonprofit. We exist only for one purpose, and that is to ensure that the very best health and healthcare are equally accessible and affordable to every living soul in our country. No conditions, no parentheses, everyone, every single person. We work in 4 core areas. That's health equity, healthcare value, consumer engagement, consumer experience, and coverage. Those are our 4 areas. We're very, very well known in coverage. Some of these are big expansions of our role. Since I came on about 6 years ago as ED. I was one of the principal negotiators in the Senate on the Affordable Care Act when it was being negotiated on the 2 committees, and worked very closely with families. Families is often credited with getting the Affordable Care Act enacted, and I think that's really fair. It was at the center of the advocacy effort. But beyond coverage, we're doing a ton of work now in value and equity. And the purpose of this discussion is to give you guys a sense of why I think that the future of the healthcare movement has to be value. We have to think about this question of value. Next slide. Families works, we're super well known in Capitol Hill and the White House and in administration, but we actually work in many, many states, in the state capitals and with governors. And we actually work in individual communities as well. And so about half of our work is actually not in DC, it's on the state level. And it's for us, it's very, very instructive. We can bring what's happening on the state level into the national dialogue, and it's really useful. Next slide. Okay, so this print is a little hard. I hope you guys can read it. I wanted to set the stage here. All right, let's have an honest conversation about where we are as a country on healthcare. All right, these are some, I think, pretty compelling statistics. Right now, almost half of our country does not get care that they need, does not get the care they need because of the cost, because they can't afford to. Half of Americans, right? About a third right now say in order for them to get access to healthcare, they cannot pay for things like food or heat or their rent, their basic necessities of life. 3/4 of the American public are not confused about this. If you ask them, and these are Democrats, these are Republicans, these are people who've never, ever even thought about politics, right? 3/4 will say, we are not getting a good value out of our healthcare system. This is not working for us. And almost 80% will tell you, if there's any role for government, it's to get in there and get us a better deal. And that's not a Democratic, that's everyone. If we have a government, the government should get in there and make sure we have a better deal. And here's some statistics about sort of in the last elections, almost 70% of voters in 2020 said this is really, really important to them in 2022. 66% of voters said that they were much more likely to vote for somebody who's really focusing on this question of how to make healthcare more accessible and more affordable. It has tremendous political currency. Next slide. The thing is, that's the American public's experience in a big sense of healthcare. This slide is probably one of the most popular in Congress for staffers and for some members. This is federal healthcare spending as a percentage of the gross domestic product. Let me see if I can get this right. Here we go. So the green line is other non-interest spending. So it's everything else we're spending on as a federal government. This light blue line right here is major healthcare programs. The dark line is Social Security, and look at our this is net interest, right? The reason that this has so much currency on the Hill beyond the political realities of voters is that by 2040, we will be spending more as a country on healthcare than anything else that we spend money on. Just let that kind of sink in, right? That means we're not educating our kids. It means we're not building the infrastructure that allows our economy to thrive. We're just spending money on healthcare, right? Next slide. On the state level, it's a very similar problem. spent a lot of time working with the governors, and the most important thing to always remember about states is, unlike the federal government, they can't print money. So they actually have to balance their budgets. And Medicaid is the largest healthcare program actually in the world now, and it is a huge part of the state budget now. It's really important to say this. It's in a tremendous deal for states, right? For every penny they spend, they might get 90 cents on the dollar from the federal government or 80 cents on the dollar for the federal government. It is a tremendous deal for states, but it also makes up a big part of their state budget. This is the projections on growth in revenue for states. The yellow line is state tax revenue, and the blue line is Medicaid. And as you can see, year after year after year after year, the growth in Medicaid spending far outpaces the revenue that states are getting. This is creating a real budget crisis for states. And it is the reason why we have teachers who are marching on state capitals and saying, I need to get paid more. Where's the money going? It's going to healthcare. Right? Next slide. This one is a real shocker. 5-year tranches, 2002, 2007, 2012. Orange premiums, blue overall inflation, and green is workers' earnings. Look at where healthcare growth has been, and this is just premium cost growth. Look at how it compares to the money people is earning, right? Look at that. It is outpacing everything. And that means, guys, that's why wages, this is one of the main reasons why wages have been flat for decades. Because we are pouring money into healthcare, and we cannot retire when we want to. We can't send our kids to the schools we want to. We can't live in the neighborhoods we want to. And for people who are low income, who are the most vulnerable, it is decimating them. Right now in this country, 40% of Americans carry medical debt. 40%. Next slide. This is another cut at the same analysis. The blue line is total healthcare budget of an average family. Pink is premiums, and green is out of pocket. This slide has a very important point in it, which is, as we work on healthcare reform, one of the things to be really aware of is it has several, but one of the most profound externalities in the healthcare market is there's all this money that you're spending that you don't even know you're spending, right? And premiums are where it's at. If you look at what's happening, our premium costs are going through the roof, and our out-of-pocket costs are flattening out. This is a strategy of the sector. How can I make sure you never know how much money you're spending on healthcare? And we're just packing into the premiums, right? And across the board, if it's hospitals, if it's pharmaceutical companies, this is their play. We're going to just keep driving our prices up. We're going to increase your premiums, and we're going to do everything we can to make sure you never experience it in a cost sharing, right? And that, anyone here ever got a drug that had a copay coupon with it? Raise your hand if you have, right? There's great examples of this. That's all about saying we want to charge whatever we can get away with, but we want to make sure you never know it. You will have no cost sharing. And it's awesome as an individual. Thank you for the copay coupon, right? But just recognize underneath that is a ploy at trying to drive up price. Next slide. So this is another really important phenomenon, which is underinsurance. This is from the Commonwealth Fund. And really the main point here is at the same time that we've done a tremendous job of increasing access to health insurance. And remember, health insurance is really about two things. It's about making sure people can access care so they can be healthy, but it's also about creating financial security so that you don't have a financial bomb going off when you try to get care. And underinsurance is basically a measurement of how much of your total income is going to healthcare costs. And what we've seen is pretty much when the ACA went online, we've seen this growth, more than doubling, almost tripling of the number of Americans who are underinsured. And what that means is that their financial security is getting worse and worse. When they access healthcare, they have the potential for a financial bomb going off. Right? Next slide. So in the last 5 years, these are some of the hottest topics in healthcare, right? Not the only ones, but some of them. And each of them represents a legislative win in DC. The first one was the repeal effort in DC under some very conservative Republicans who decided we're getting rid of the Affordable Care Act and we're going to take $1 trillion out of Medicare and Medicaid and the exchanges. We won that fight, and we were really proud of that. And Deborah's organization and families and a bunch of us worked really hard on that. But I want to be clear, the reason we won that was two things. The first was there was a truism in DC, which was no one will ever show up and defend Medicaid, ever. And everyone showed up and defended Medicaid. So we learned a lesson there. People will show up and defend Medicaid. But the second thing, and this is really the main, I would say, reason we won, is pre-existing conditions, right? You guys may not be old enough to remember this, but there was actually time in this country where you'd pay your insurance premiums, and then all of a sudden you get sick, and the insurance company would go back. This was if you had an individual policy. They'd look through all the paperwork you filled out, and they'd look at your medical record and say, oh, you know what? You didn't say this. And sometimes the this is, you never told us that you had an allergic reaction in the ED when you were 15 years old. We are rescinding your policy. Good luck to you, right? Or that you actually had this before we covered you. So you get no coverage for that, right? That was a common practice. In the District of Columbia, a woman who was a victim of domestic violence could pay more for her health insurance because guess what? When you are a victim of domestic violence, you cost more, right? We got rid of that in the Affordable Care Act. It is crazy that we ever lived under that for decades, but that the American public are not confused about. We should not have to pay more if we are sick. We should be able to pay our premiums and rely on our insurance and get real financial security. Surprise medical bills. This was an all-out battle. And I was telling some folks during lunch that we were just about over the finish line on this one, right? And COVID hit. And there was a package that was moving in April. It was going to go in there, and everything ground to a halt. And we kept pushing. And my phone started ringing from all the hospital associations saying, what are you guys doing? There is a pandemic. Do you not know there is a pandemic? How could you do this? How could you come after us and kick our legs out from under us in the middle of a pandemic, right? My response was, one, you guys all endorse this legislation. So honestly, why are we having this conversation? And two, how can you do this? How could you possibly send a surprise medical bill to a family in the middle of a pandemic? Have you lost your mind, right? And we can talk a lot more about this, but this is the other one. This is the kind of issue that creates currency and political change. Prescription drug pricing reforms, right? We just won this, and we have been fighting this for decades. 10 years ago, it was a totally different conversation. It was basically farmers off the table. Don't even think about it. And we actually won this. For the first time ever, the federal government's able to get in there and say, hey, this is a crazy abusive price. We're going to try to negotiate something that's fair, right? And now the latest hot topic is hospital pricing abuses. This one's going to be really tough. Did you know that since 2015, hospital prices have gone up 4 times faster than people's paycheck? Did you know that in a hospital that consolidates, you are going to end up spending somewhere between 20 to 40% more for your healthcare, and your quality goes nowhere? In fact, the average family pays $1,000 a year when their hospital consolidates. The average individual spends $400 a year, right? That's happening under the cover of darkness. And it is killing our families' economic vitality and their health. Next slide. Guys, these are really important. This first chart right here is my favorite one. This is a measure called treatable deaths or healthcare amenable deaths. Very smart clinicians like Mark and others sit down and look at medical records and they say, somebody came in the system and then they died. And should they have died, right? And they've been measuring this for many, many years. This is the story of the American healthcare system. We're the top line right here. These are a bunch of other wealthy industrialized nations. Look at where we are compared to the rest of the world and look at what's happened to us. We started in a terrible place. We've made some improvements. Everyone else is far outpacing us. And by the way, Japan, which is over here, they're spending almost 3 times less than we are in healthcare. Our system is not at the top of the pack, it's at the very bottom of the pack, right? This truth has got to be unveiled. If you are going to die, if you have something that could kill you, don't go to a system in Australia. Go to a system in Japan, right? The American people need to know this. For all the money we're spending, that's what we're getting. And then preventable deaths per 100,000, that's a good measure of sort of population health, public health, prevention efforts. And here we started much worse than everyone else, and look where we've landed, right? What are we getting for trillion a year that we're spending. What are we getting? Right? Next slide. Life expectancy. This is another kind of sometimes called a metametric, right? Look at where we are compared to the rest of these developed nations, right? All the men in this room, you should probably move to maybe Switzerland, right? And all the women, I think Japan's where you want to be, right? But the idea here is I think one of the things that really, for me, working on the Hill and working on legislation and on public policy and state capitals, I think that this is about a bargain that we're striking. We're going to spend money as a country and we are supposed to get something in return, right? What are we getting in return? Next slide. So let me tell you a story about Deborah. One of the things we do a lot of work at Families is on storytelling, which is for a very good reason. It's about adult learning. It's how we actually remember things, stories. It's also the best way in the world to cut through partisan BS, right? You can say whatever you want to say. You can have your talking points. But when the person is standing in front of you and telling you their story, it's very, very hard to stay on that talking point. So Deborah, and you can click through, there's like 6 of these. You can click through all of them. Perfect. Deborah is from Tennessee. She was one of the first people in her family to go to college. She worked really hard. She was very successful. She became a microbiologist in Tennessee. So she took her talents to work for the good people of Tennessee, working in public health. She's one of the first people in her family she was the first person in her family to buy a house. She bought a new car. She was extremely proud of all of her accomplishments. And then in her 50s, she started having trouble getting around, and it turned out she needed a hip replacement. A extremely common procedure, a very successful procedure, a very good use of money, right? Particularly for a 50-year-old who's got a lot of life left to live. And it's a great way to make sure that she can stay healthy because she can continue to move and she can still be a functioning member of society. She went in the hospital, and as she was getting her hip replacement, she got a hospital-acquired infection. In our system today, 250,000 people a year die because the system kills them. 250,000 people a year die. Deborah's infection spread from her hip and from the incision into her spine. Her spine basically collapsed. She was put into a medically induced coma, and therein her journey started. She's been on $900 a day antibiotics drips. She's been inpatient for months upon months. And she's currently still bedridden. She's never been able to get out of bed after this because the system hurt her, right? But the other part of Deborah's story, and it's so important to say this, is where was Deborah getting her health insurance from? Her job, right? She was a microbiologist. She had great insurance from the state of Tennessee. What happens when the system makes you sick? So sick that you're in a medically induced coma in the bed, in a hospital bed. You can't work, right? And over time, COBRA, is incredibly expensive and it runs out. And she, actually, I think she went straight into short-term disability, but eventually she had to come up with a way to pay for these hospital bills, right? Month after month after month after month. And guess what happened? She started impoverishing herself. They tried to take her house away from her. They took her car away from her. Right? In this country right now, if you get diagnosed with cancer, almost half the people with cancer within 18 months will be bankrupt. Within 4 years, it's many, many more. That's the other story of the American healthcare system. That doesn't happen in Europe. That doesn't happen in Norway. Right? And any of us could be in that position. That's the craziness of our system. Right? Next slide. Okay. So picking up on that point, health equity. Right? Really, really important point. We are going through a very interesting moment as a country. For some of us who've been working on health equity for a long time, it is incredibly energizing because we are having an awakening to health equity. For others, it's kind of a first-time experience. And let's talk about health equity for a second. Next slide. So, just to level set, right? I hope everyone knows this. These data are super clear. Right now in this country, you are twice or 50% more likely to die prematurely from heart disease if you're African American. 50% more likely. The infant mortality rate for Blacks is more than double the rate for whites. And fewer than 1/3 of adults of color are getting treatment for mental illness, while about half of whites are. That's not enough in either side. But the point here is these are real disparities. They exist. Next slide. So we do a lot of work with there's some great national survey data around health. And right now, Blacks experience poorer health than whites, 24 out of 29 measures, right? Native Americans, 20, Hispanics, 13. And 9% of non-elderly adult whites in the US report being in poor health compared to 11% of Hispanics and 17% of Native Americans. There's no question about this. We are not providing health to people of color in this country in an equal way. And if we go back to the original premise, we all rise and fall on the ability of people to live a healthy life. Okay, next slide. Here are some COVID statistics. Now, this is early COVID before the vaccines, and I want to say we were working very hard with the center. I'm incredibly proud on vaccine equity. As you guys know, we actually turned things around. And in this country, we actually saw people of color get protected when vaccines were made available, and their death rates plummeted. I'm super proud of that work. It took a lot of really, really intentional work. The center was at the center of a lot of that. So really proud of that work. But this is early COVID. So think about it this way. A stressor hit our society, a healthcare stressor. It just hit our society. And our society was operating as it always did with all of this inequity, with the structural racism and inequity that is implicit in our society. And look at what happened. Black people were dying at 2.4 times the rate of white people, 90 deaths per 100,000 compared to 38 for white people, right? Boom. Next slide. These to me are the most startling. Arizona, New Mexico, and Wyoming. The bottom bars are the percentage of the population that each of these Native American groups represent. So in Arizona, Native Americans were 4% of the population and 18% of the deaths. In New Mexico, look at New Mexico. I've spent a lot of time working in New Mexico. You were 6 times more likely to die from COVID if you were Native American, right? Wyoming, you were 15 times more likely. That's the country we live in. Next slide. So the Kellogg Foundation has done a really nice job of really analyzing this. And so from an economic standpoint, you can say the moral cost of health inequity, we lose 3.5 million years of life in our country. It costs the system almost $100 billion, and the total cost is about $135 billion in economic loss. These are real, these are tangible, it is happening. But to me, for folks who aren't totally convinced, the demographic imperative is really the point, right? In 2011, the majority of births in this country were kids of color. I am the son of Cuban refugees. I'm part of the Latino wave. You're welcome. And this is happening, and it's real. In 2020, a majority of our kids were kids of color. And by 2045, guys, all of you are living through the next 23 years. We are going to watch the power of this country shift from a majority white population to a country of color. That is happening on your watch, and it is a lot. And there's a lot we need to do. But at the end of the day, if we can't solve health inequity, we fail as a country. That's where we are now. There's no question about it, and this has to get solved. Right. Next slide. We would posit, so social determinants of health, raise your hand if you haven't heard about them. Excellent. Before, it used to be when I was in my MPH program, we were the only ones who heard about them. Now everyone has them, which is awesome. But the real point here is somewhere, no one knows for sure, but somewhere between 90 to 80% of all the things that impact your health have nothing to do with the doctor you see or the hospital you walk into, right? It's all this other stuff. All of this other stuff. And what we know is the systemic racism in our country has a really good way of impacting all this other stuff in addition to our healthcare system. So if we're going to tackle health inequities, we have to think about this in a global way. We can't just think about it in terms of the healthcare system. But of course, there's important work to do in the healthcare system. Next slide. So, we would argue, and we can really get into this in the questions and answers, but at the end of the day, why is it that we have such a terribly inefficient healthcare system? And what we would say is it's the economic incentives that our system is responding to. Right now in this country, every single hospital, every single physician, every single payer is aiming at one thing: high margin, fee-for-service procedures. High margin, fee-for-service procedures, right? Let's do the procedure. Let's do the really expensive test. Let's give you that implant that's going to make us $50,000, right? That is what the system's aiming at. But that isn't really what delivers us health. And so what payment reform is, and the center is very focused on this, as we are too, is about saying, let's have an honest conversation about that. And let's change the economic incentives so that a hospital, a physician group thrives because their patients are thriving and because their patients are economically stable, right? That is what payment reform should be about. That's what we're trying to do with payment reform. But I want to say this, on health equity, it could really go either way. Because at the end of the day, and we can really dig into this on the kind of models we're talking about, at the end of the day, when you look at the way in which the systems are responding to payment reforms, these new incentives, what they're trying to do is create a standardized approach to reduce people's risk and then capture the value of that. So they're saying, look, we would have spent $100 on you, we're only going to spend 80, and then we'll share in the savings, right? That's kind of a basic way to think about it. Well, what happens to non-standard populations in that model? They get pushed out. And we can talk a lot about this in the Q&A, but at the end of the day, if we are not intentional about equity in payment reform, it's not just that it won't solve it, it's actually going to make things much worse. And I actually saw this front lines in the systems as they were responding to the payment reforms that I helped write in the Affordable Care Act. I saw them reacting to them. And they were saying things like, you know what, we need to shut down our housing interface to help people who are homeless find housing. We need to shut down our language program. We need to shut down our transportation program because those programs bring in non-standard populations that aren't going to react to the kind of interventions that we're generating. That's an example of how that's going to make things worse. So we really have to center payment reform not just on the economic and value needs of all people, but we need to center on equity, or we fail as a country. Next slide. So I don't want to leave this on a negative note. I want to leave this on an up note, which is these are the example of 5 really powerful strategies that do 2 things, okay? They will change a person's life, they will improve their healthcare, and they actually save money. And the reason that's important is we have, and this is an unusual thing for a healthcare advocate to say, we have more than enough money in the system. We really do. What we have is a terrible level of inefficiency and waste and poor outcomes. And so to solve this, we can't just raise our fist and say, spend more money. Let's go do a housing intervention. Let's go do a behavioral health intervention. Let's spend more money. Because I'll tell you why we can't do that. Because you saw the slides at the beginning. The policymakers are drowning in healthcare costs. If our strategy is add more costs, we're not going to win. But if you go to a governor and you walk in her office, and we did this with their Medicaid directors and Secretary of Health, and we say, Governor, and she says yes. We say, we know you want to get it. We know you want to get this right. She says, I absolutely do. And you say to her, how about this? We have figured out a way to take some of our healthcare spend and direct it towards the social determinants. And not just will we change the lives of the people, but we will actually save you money. You've got her attention, right? You've got her attention. And the most important point is everything a governor deals with is on fire. So you've just taken something from being like, if only to, wait a second, you're solving a problem for me and it's good public policy, right? That's where we need to be. That's the center we need to be in. So behavioral health integration, this is, we can go into all these models if you want. This is the best one, is the collaborative care model. It's incredibly powerful. Guess what? People who have unmet behavioral health needs spend a ton of money in healthcare and they don't get any better, right? There's, I think, 70 clinical trials that have shown, randomized clinical trials that show they save money. Empowering primary care providers, we can really get into this. There's a couple different flavors. Vermont Blueprint for Health is showcased here. We're talking about, $500, $800 per person in savings when they really wrap powerful primary care around the right populations, targeted populations. ED utilization, incredible example, saved about almost $400 million in 1 year. And this was Washington State. And they figured out, by looking at their data, they figured out that they had an opioid crisis about 4 years before the rest of the country did. Evidence-based housing first. This is an incredible model. When it's targeted at complex patients, you can save hundreds upon hundreds upon hundreds of dollars. And let me tell you, the thing that's most exciting to me about that is it's really hard for the non-healthcare people to understand the amount of money we're talking about. $4 trillion is, kind of a staggering amount. When you go to a housing advocate and you say, hey, I can come up with 10 grand for you to help this person, they're like, I can change their entire life. And you just saved 90% of the spend on the healthcare side, right? It's the power of the waste. We have money to move around here if we get this right. And the last one is coordinating transitions in care. I think the best example of that is right here in North Carolina. It was right here in North Carolina, the North Carolina Community Cares Program. It was a terrific program. It was under siege all the time. It's been studied a million different ways, and it saved over $350 million to the state Medicaid program over 3 years. Right? So we can do this. We can do this. Next slide. It's my last one. So this is to give you kind of a way to think about this politically. So if there is a political continuum, I would say this is it. We've got the repeal legislation in 2017. We've got Medicare for all on the other side, right? One is less government intervention. I just see somebody up there going, it shouldn't be the other way around. I did that on purpose. That's exactly right. Let's not think left and right, people. Let's just think ideologically. All right, so less government funding with little control or cost and quality. Repeal was really about one thing. It was a recognition by conservatives that healthcare spending is out of control. And they are right. It is out of control. And what's the answer? We are offloading federal risk here, people. We're taking $1 trillion out of healthcare spending. We're pushing on the states and on individuals and on employers and saying, good luck, figure this out, right? It's a very rational move. Politically, as long as we can explain to people what's happening, it's pretty hard to do because you're really hurting states and people and businesses. But it's a very rational move. The other side of this is Medicare for all, right? Let's get the government in there. We'll set price. We'll make sure everyone's got coverage. And you can't go to the doctor you want to see. We're going to put you in the doctor that's negotiating price with us, and we're going to get a handle on this, right? That's the other side of this. What I would argue there is another big lesson of the healthcare sector the last, say, 20 or 30 years is there is a constant dialogue occurring in healthcare policy between the really smart, well-meaning people who are within the federal government, who are running the agencies, the folks who are setting Medicare policy and Medicaid policy. Mark was one of the most senior people in that, right? And they're constantly thinking about how do we drive the policy in the direction that is good for people. And the other end of that is some very well-paid consultants from Deloitte and McKinsey and the advisory board company where I used to work, right? Who are hired guns by the healthcare sector to say, how do we screw this totally, right? And when I was at advisory board company, I developed a health policy division for them. And we would bring the CEOs and CFOs to the White House, to the committees of jurisdiction, and they would say, this is how we're totally screwing you. This is definitely not what you want is not what's going to happen, right? So I just want to say for all of those folks who are out there, and this is not something I would say, I don't say this lightly, but I see the appeal of Medicare for all, and we've got to solve this. And we certainly cannot make the most vulnerable in this country bear the brunt of how inefficient our healthcare system is. But the idea that the government is going to be able to have that dialogue with these very, very high-paid, very sophisticated consultants and win, I think, isn't really going very well. And APMs, the alternative payment models that we're describing, where we're saying we've got to realign the financial incentives so that a hospital's making money because their patients are healthier. Because when they get sick, they're getting better fast, right? And their quality of care is high. It's the middle path from like a Buddhist perspective. That's the middle path, right? That's what we're aiming for. And it's been going on now for over a decade. It's not been going well. The APMs are having in my opinion, not nearly the kind of impact they should be. And they've been used over and over again by the sector to consolidate and drive up price. Time is growing short. We've got to get this right. And there's a lot of folks out there who are trying to push really hard on, we got to get more risk. We got to disrupt markets. That's where we need to go. But at the end of the day, we also need the American people to understand this. And we need a movement. We need people waking up to what they are living with in this country. And so I think right now at families and a lot of other organizations, what we're trying to do is wake people up to this reality so they can show up. Because in every seat I sat in, when I worked I started working with public hospitals, then I ended up working in the Senate, then I worked with governors and with industry. In every one of those seats, at the end of the day, we're talking about inverting the economics of 20% of our economy, right? In every single seat that I sat in, at the end of the day, you push, and they say, look, I want to be really, No one's really asking for this. You're asking us to do something enormous and impossible, and no one's asking for it, right? We need a movement. We need the American people to say, we're fed up. Time is up. We've got to do things differently. And that's what we're trying to build up there.
There's a lot of ground to cover in a limited amount of time. Come on up. We're going to sit down and talk a little bit more about this. And for those of you here in the room, and we're going to have time for some questions in just a few minutes. For those of you online, please send in questions as well. Let's start with where you ended. We need a movement to wake people up about value. Now, you started out talking about value in ways I think normal human beings understand, which is the affordability, like what they're paying out of pocket for their health care. And you talk in particular about high and rising hospital prices. So maybe we'd start with that one, because that one's kind of most obvious to people, yet the prices keep going up, especially for commercial or employer plans. So what's on the top of the family's list for doing something about that? You mentioned consolidation. Is that it? Price transparency? What would be at the top of your list?
Okay, so we have very strong feelings about this question. So. Yeah, and so I think it passes prologue. You kind of learn a little bit, right? And think about where we got as a country on prescription drug pricing and how bad it got before we finally, in this, 3 months ago, we finally passed a law to say these abuses are insane. We're not doing this anymore, sort of. I mean, I also jokingly say the Senate is where all great ideas go to die. So it's not the strongest bill that could ever pass. Yeah, I did. It's not the strongest bill, but it is such a foundational moment where we're saying, you know what, we can get in there and negotiate for a fair price. And that's not where most Americans think about their hospitals, right? I mean, hospitals, I honestly do remember when we grew up in Winston-Salem down the road, and Krispy Kreme, it's the headquarters of Krispy Kreme. We would sell the donuts for the hospital, right? Like, we want the maternity wing to thrive. And that was the hospital back in like the 60s and 70s. That is not the hospitals of today. They are giant, corporate behemoths. And that local hospital became a health system. That health system merged, and now it is a corporate giant.
You're not making me optimistic about change.
So the first thing we have to do is unveil this reality. We have to unveil it. And I would say that the number one thing we have to do is unleash data. People need to understand what these prices look like. People need to understand that they walk in hospital A and hospital B. Hospital A is giving women hospital-acquired infections when they go in for their deliveries. Hospital B is going to end up, you're going to come back for a readmission, right? We have to unveil that stuff. There's no market here. We don't have real competition. We need to really, and what we'd say is we have to make status quo really, really, really uncomfortable. And one of the ways we do that is through transparency, through unveiling the inefficiencies.
There does seem to be some movement there, not only some of the previous price transparency laws about specific hospital prices, but also, for example, Medicare's announcement last week about moving to transparency around the cost of episodes of care that people commonly get in hospitals, and wanting to work with the private sector on that too. Okay, so that's an important step. But you also talked about, and that really very sad story about Deborah, about how it's not just the price of the service, but the combination of services, trying to get the right treatment to the right patient. That seems to fail a lot too. And as Bob Margolis would say, the cheapest hospital price is the one that you avoid by avoiding the hospitalization or the complication in the first place.
Yeah.
So thoughts about how to connect that push towards, and you talked about value-based care and alternative payment models. That's not something that rolls off the tongue for like a normal consumer who's worried about a lot of other things. So how do you connect on that?
So two thoughts there. One, and I don't want to be a broken record here, but I really do mean this. I think that first of all, at the end of the day, what was the cost of the surgeon who gave Deborah an infection? No, actually, he made money, right? There's no cost. There is no real accountability in this system. Really, truly, you're only gonna be held accountable, if you're drunk during surgery. I'm not kidding, or you take off the wrong leg, like that's the level of accountability we have in the healthcare system today. So first, the unveiling the transparency is about creating real accountability, right? But to Mark's point, the other side of this is that for the last 10 years, payment reform has been a green eye shade behind the curtain. Trust us. In the end, we're going to get to population health and people will be healthier and costs will go down, right? And what we realized is in that effort, the sector just has completely gamed it. And the other side of it is, and people have no idea what it is. In fact, it's gotten worse than that. Right now, there's a group of progressives on the Hill right now who have gotten confused about Medicare Advantage, private coverage in Medicare and payment reform. And they're actually aiming at payment reform because they think it's Medicare Advantage.
And just to expand on it a little bit, you're talking, at least I think you're talking in particular about new initiatives from the Biden administration, like the ACO REACH program, which is intended to be a big shift away from fee-for-service for organizations that are ready to take on, these new models of person-centered care, and with a big push within that towards so-called social risk adjustment, meaning paying more for the organizations that take on more patients and more care in underserved communities, and strong opposition from the progressive.
That's right, because it's for a very good reason, because Medicare Advantage has run around the Hill. First of all, you should know that when Medicare Advantage was created, by definition, it was supposed to be more efficient than fee-for-service. So they were going to get 5% less than fee-for-service, right? They were going to do things for less money because it's private sector. It's more efficient. Today, they get about 107, 108% of Medicare. That's baked into their, and you know what they do with that money? They advertise crappy eyeglasses and crappy hearing aids and get everyone to enroll in them. And the numbers are creeping up. But they also run around the Hill and say, well, we're capitation, right? And they get a capitated payment for every single one of their patients. But underneath that capitation, they pay fee-for-service to everyone. And the fee-for-service payment builds the actuarial payment that becomes their capitation. So they're feeding from the same fee-for-service trough, but they're calling it capitation. That confusion has now created, as Mark said, complete opposition from progressives. They don't want to see traditional Medicare just bleeding into the private sector, but they don't understand that at the end of the day, if we want to, and a lot of these folks are really thinking about the most vulnerable, if we want to change the lives of the most vulnerable, what Mark's talking about is the way to do it, to create a payment around health and around getting people healthy and flexibility. Like, I need somebody to coordinate my care. I need somebody to help me get to my appointments. I need someone, I'm in Medicaid and I'm housing insecure, right? I need somebody to help me with that. Those are the ways in which we can actually reduce costs and improve people's lives. And it's all this model that Mark is talking about that we're fighting for, but there's people who are very confused about that right now.
And you talk about the steps that you're taking to address that confusion, which I agree seem very important and timely right now for what hopefully could be a bipartisan effort.
It has to be bipartisan. It has to be.
But let's talk about Medicare Advantage and private plans more generally. So what would be the path forward? MA is close to half of Medicare beneficiaries now, and it's been growing in part because of those additional benefits coming from those additional payments. But what about Medicaid? That is the, as you said, largest source of insurance, single source of insurance in the United States, one of the largest in the world. And that one is already generally delivered through private insurance plans. Right. So what do you say to progressives who are concerned about the role of the private sector, but it seems like, Frederick, it's kind of embedded in delivering care to the populations that you're most concerned about from an equity standpoint. How do we do that? Is that going to change, or how do we do it better?
Well, and important to say, as Mark's pointing out, like, the horse is way out of the barn on the Medicaid side. Almost all care in Medicaid is being provided through these private health insurance companies who are providing Medicaid managed care. So that debate is over. And I will say that, to me, that discussion about will payment reform hurt or help health equity, I think for me, it became clear. So when I was at Advisory Company, we were spending a lot of time with the Medicare, the health systems that were trying to reorganize payment reform for Medicare or private coverage. Those are their private coverage is their biggest margin, but Medicare is also a very high source of their profitable services, right? And that was where you saw them saying, okay, we have an intervention for the people who are rising risk, people who will end up needing really a lot of care. We can do all these things to stop that from happening, and then we get to share in the savings, right? We can do all those things. But for people who are housing insecure, don't have transportation, language access, all this, those people are terrifying, because the things we want to do to that population to stop them from getting sicker, it doesn't work for them. Their life is more complicated. And what we're talking about really is the people who are economically most vulnerable in society don't have this cushion that allows them to do all the things the healthcare system should be doing for them, right? So then when I got to the Governors Association and saw what was going on in Medicaid, it was a totally different story. right? It's that list I gave you. They're like, wait, no, we can't run away from people who are housing insecure. Those are our people. And so Medicaid can be, I think, is a source of some of the most incredibly innovative and exciting changes, all focused on redesigning the economic incentives to allow providers to thrive when their patients are thriving. And you guys, one of the things that's so magical about this moment is there's so much waste in the system. It is hard to explain the amount of waste. We worked in states where we said to them, all we're going to do, let's look at your data, let's figure out where their spend is out of control, and let's figure out why, and let's do an intervention. And like in one state, up way up north, they did this and they found out, wow, we've got this massive amount of ED utilization. It's extremely expensive, right? They opened a clinic in one neighborhood. After hours, they saved $15 million in 1 year. Like that's how easy it is right now. The pioneer ACOs that were the first ones out the gate on payment reform, there was an incredible CEO. She was a nurse who became a CEO. A lot of the really interesting work is being done by nurses who become CEOs. And in 1 year, they reduced their readmissions by 30%. And she said to me, Frederick, this is not hard. We know exactly what to do. This is not hard. But only 10% of her book of business was in risk. So she took a bath and her board almost fired her. Right?
And are there steps that states should be taking or that CMS, the federal government, can take to encourage or support the Medicaid plans and for that matter, the Medicare Advantage plans to get this right?
Yeah, well, I would say, and again, to just be back on this, the first thing we need to do is have much more data transparency so we can actually hold people accountable for cost and quality. Like we can't take their word for this, right? We need to be able to look at the data and say, are you actually improving outcomes and are you actually saving money? And it's a prerequisite and it's very hard to do. After that, there's a bunch that we can do. We have authorities in the federal statute around Medicaid, particularly 1115 waivers, which allow states to perform experiments that say we can shift dollars. If you can spend less on the acute care side, we can let you spend more on the social determinants. And Oregon was the first one on the gate on that. They've saved, I think now they've saved something like $10 billion to the federal government by doing this, right? So there's really important authorities. I also think that at the end of the day, I mean, on the conservative side, big talking points came out on the end of year package that's being considered right now. This was one of the things they aimed at. They said, look, guys, Medicaid's now paying for housing. Medicaid's now paying for behavioral health that's not being provided in a clinical office, right? For social services. They're not wrong. That is true. And that's why that point I made earlier about we've got to strike a bargain here, which is progressives want to solve a problem, but they don't always want to own how complex the political solution is, right? We have to strike a bargain no one can say no to. And we're saying, yeah, we want to pay for housing, but only because people's outcomes are getting better and we're saving money. Who is going to argue with that, right? I mean, people will argue, but they will not win that argument, right?
I want to go to, there are a lot more questions
Sure.
I could ask. Great discussion, but I want to go to some of the questions that are coming in. We've gotten several online. Thank you all for sending those along. Any questions in the room, though, that I could go to one? Okay, while you all are thinking about that, be ready to put your hand up and let us know. But you talked a lot about primary care as an important part of the solution here and expanding primary care. So one of the questions was about, can you mandate increased primary care spending? Or what would you say is the best policy for expanding and strengthening primary care?
Okay, so there's 3 flavors that have been very successful, and they're all totally different. And the first, Rhode Island, and all they did was they said for every increase in healthcare spending, the vast majority of it has to go in primary care. So every time hospitals wanted to kind of get more money, they had to make sure most of it was going to primary care, and they literally changed the face of delivery in Rhode Island just by doing that. Super blunt. And that's the thing, right now the solutions can be very blunt. Second example, Maryland Care First, right? Their model, the most elegant model, the one everyone's talking about is Vermont Blueprint for Health, where they said we're going to find very complex patients who need a lot of coordination. Maybe some of them had opioid use disorder, things like that. And we're going to wrap coordination and primary care around them. And we're going to make, or behavioral health, unmet behavioral health needs. And we're going to make sure they get the care they need. That's a beautiful, elegant solution. But there's, that's not everyone that needs that. But primary care has other roles. And the Maryland model is a perfect example of that. In this one, Blue Cross Blue Shield said to their primary care doctors, we're going to give you a bonus. And the bonus is going to be at least 1-year tuition at Duke University. No joke, right? Or more. Really expensive sports car, something like that.
Literally, yeah.
Not literally, but that amount, that amount. And more, it could be twice that, right? And what we're going to give you data about something you never have as primary care doctors. What the hell happens to your patients after they leave your office? We're going to tell you, here's where they're going, here's their outcomes, right? And we're going to tell you how much it costs. And if you help us send your patients to providers who are doing a really good job and are not spending gobs of money doing nonsense things, right? You get the bonus. They saved almost $400 million over 2 years, I think, in that model, right? That's another way that primary care can take and that really, when you look at the population health models, at the end of the day, that's what you want, is you want primary care there as a coach negotiating its way through the system. The problem we have is, in this country, about almost 3/4 of doctors now are not primary care. So what happens to all of them, right? There's a lot of entrenched interests that are not particularly interested in seeing this model thrive.
All right, so that's another good question I could ask you as a follow-up, but let me see if there are any questions in the room. So I'll keep going online.
Actually,
Yes.
do Deb first.
I was just going to take you back to the issue of equity, APMs. So you said APMs could make the problem worse, but can you give examples of how APMs can make the problem go away?
Yeah, and just to repeat the question for those online, question was about how alternative payment models can make equity problems worse, unless, as you said, there's intentionality about not doing that, about making it better. So
right.
Say more about that.
Okay, so the 5 examples I put up on the side, those are perfect examples of how APMs can actually make health equity stronger, right? So what are the needs that we know that the marginalized populations in our society are most likely to need? 1, unmet behavioral health needs. That's number 1 on the list. 2, it's access to primary care. 3, it's housing instability, right? These are the things that can really change people's lives that are living in a very vulnerable situation. So those are examples of concrete reforms that save money and can change lives of vulnerable people. It's kind of that first level. If you want to go deeper, and I think this is where I know Deb really wants to go, I really want to go. If you really want to go deeper, ultimately, what we can do is we can take that unit of risk and not make it the hospital or the physician group, but actually make it the community. We can actually, and this is what the Oregon model, the CCO model, in Oregon, we negotiated the waiver for Washington State on their accountable communities of health. This is what the model looks like. The idea is, let's build a table of the resources within a community, like a health plan, a hospital, social services, behavioral health, public health. Let's have them come together. Let's have them look at their data, figure out what's happening in their community with the data, right? And this is actually based a little bit on a community organizing principle, the Paulo Freire from Brazil, this idea of empowered community, right? You sit down together at this table with the data and you say, okay, guys, here's what's happening in our community. Is it unmet behavioral health needs? Is it substance use disorder? Is it obesity? Like, what's happening? What do we really want to aim at here? Is it hospital readmissions? Is it infections, right? And then that table has the ability to redistribute dollars to solve that problem. And guess what? We're going to come back and we're going to measure both outcomes and costs. And if you've been able to improve outcomes and reduce costs, keep going. Here's more money. And over time, you titrate more and more money into that community table to solve the problems of the community. And the best thing about this model is we did this in Washington and Oregon. They're doing it in Minnesota, but they wanted to do it they were doing it in Wyoming and they were doing it in Alabama, because community is not red or blue. Everybody loves community, right? It's the unit of intervention. And I would say, to get really, really meta on this, the intervention is actually that community table. And at the end of the day, if we do this right, that community table can tackle education issues. It can tackle workforce issues and economic issues, right? We have to reorient our public policy into community level and not at this either state or federal level.
Frederick, you touched on it. We're about it. Luke's going to let us go another minute or two. I have to ask you like that. So good. It's not good for you. So I'm going to ask you a hard follow-up. Okay. But for this last question, basically the main question was, how can you get enough leadership to promulgate this, what clearly would be an unprecedented level of change? And maybe if I could connect that back to, you touched on the experience in the pandemic of where we saw some really disturbing inequities get exacerbated involving racial and ethnic minorities, but you also talked about how that got corrected. And I think a big part of that from some of the work that we were connected with you all on was around this kind of community engagement and really reaching people where they are. So that was a good example, but in terms of everyone getting behind that, some equities that we haven't addressed in the pandemic involve differences for rural populations. Those are still there. Differences for people who are conservative leaning. For all of these communities to come together, is there more leadership needed for that?
Yeah,
what else is going to be critical?
Without a question.
And this is also your
my wrap up. I got it. So, and let me make a wrap up point on this. So, on my board at Families, we have former governor of Oregon, Governor Kitzhaber. He was the father of the CCO movement. This has been his dream, was to reorganize financial incentives so that doctors and nurses and community health workers can do what they actually want to do, which is make people healthy and get them better, right? And he tells a story about watching, as a young ER doctor, watching a baby come in and die because it didn't have any of the prenatal care it should have gotten, while a woman was hooked up in a coma in a bed for months upon months upon months. And he was saying, as a young doctor, what decisions are we making as a country, right? There are not a lot of Governor Kitzhabers in the political arena. We can't count on the Governor Kitzhabers to be showing up as governors or as senators. This is not, it's a very, very rarefied kind of set of life experiences that lead you to that point. So we got to be clear about this. We're talking about 20% of the economy, and we're talking about a heavily consolidated industry that is getting more and more consolidated. Anyone who studied political economics knows that means far outweighed political influence. The only way we're going to get there is a movement. Period. End of story. We need a movement. We need a movement. That's what brought me to Families. We need this movement. So I think the most important point I want to make is, for all of you who care about this, for all of you who want to have impact, make sure that you've thought strategically about how this is going to happen, because it is not going to happen because you walk in the door of the Senate or the House and say, I've got the solution. Let's go do this. That isn't going to win the day. It's got to be about a movement. It's got to be about aggregating power. We've got great people on our side. We've got the large employers. We've got the small employers. We've got the labor unions, right? We've got the family physicians. They're all on our side on this. We've got to come together and build a movement if we want to get this done.
And this is not an issue that's breaking down neatly along party lines.
No.
We talked about in this discussion.
No, we've got some no surprises with bipartisan. There's lots of Republicans. We've got like Republican senators who are very successful business people. And they're like, this is completely ridiculous. You are not competing hospital. You are driving competition out of your markets. You are just raising. I wish I could have done this as a business person. Why do you think you should get away with this, right? This has to be utterly bipartisan.
All right. And on that enthusiastic, Frederick, thank you so much. All of you joining us in person, all of you joining us online, stay tuned, stay in touch with me. Our goal is for future presentations on these and other really timely topics. For right now, have a great rest of the day. Thanks so much again, Frederick.
You bet. Thank you, Mark, very much.